All right, while we're working on that, everyone, I'm going to go ahead and introduce our speaker. So we are fortunate to have Dr. Marra present to us today, and we haven't heard...
That's debatable right now, right?
No. You're going to win us over in no time. We haven't heard a lot about nutrition, but we do have nutrition is embedded within a lot of the things that we do, a lot of our programs and a lot of our services. Dr. Marra is actually West Virginia native West Virginia, right?
Yeah.
So fantastic. We like when we get to keep our own. She has a bachelor's degree from WVU in Human Nutrition and Foods, and then she completed the graduate dietetic internship to get her master's degree, and then, of course, for dietetic registration. She practiced as a registered dietitian nutritionist in Maryland and Florida, so she left the state and then came back. She got her doctorate degree at Florida International University in Miami, which we're jealous. Wonderful weather, I'm sure. And then had a postdoc. She wasn't done with her training. Postdoc associate at the National Center for Nutrition, Physical Activity, and Aging at Florida International University. So since being back, she served as the Director of Nutrition Services and teaches medical nutrition therapy to our undergraduate didactic program in dietetics, and then does a lot of research on applied nutrition laboratories. So some of those experiences we're going to hear today. Again, you know, the Grand Rounds gives us a chance not only to learn more expert knowledge from those who present, but also learn more about our peers here within the university when we have speakers from the university. So with that, let's get on to your presentation, and I'll be quiet. Melissa, real quick, I'll monitor the chat, but if anyone has any questions, we're going to try to reserve some time at the end for those, okay? So let's see.
So let's get those up. First, thank you. I know you're probably second-guessing the invitation now, but thanks for inviting me to talk about some of my research today. I also, when you talk about my background a little bit, I just wanted to add that during my master's degree, I worked there at the center. I did my graduate assistantship there at the so I got some practical experience in the feeding and swallowing clinic, and there was a seizure clinic, cleft lip and palate clinic. So I had worked there a bit during my graduate program. So I had that experience, and then when I went to Maryland, I also had some experience working with people with mental disabilities that were aging. And so then I continued on the aging track, which led me back to West Virginia. I'm missing my parents a little bit. You know, initially you can't wait to leave and to go away from your parents, and then eventually I got to where I was wanting to get back home close to the family. So I arrived at WVU, and then it was time for me. My job would be half teaching, which I enjoyed very much, but the other half was research. So I found myself having to develop a research program from scratch because unlike some career paths, after getting my PhD, I did not go back. I did not go right into academia. I went back into clinical practice, and I was working for a large group of gastroenterologists in South Florida, about 52 physicians, and I traveled to their offices and provide clinical care. So when I came back, to develop the research program, it was basically the same conditions that I was treating are prevalent here in West Virginia. So I just went with what I knew and started into the reducing diet-related health disparities.
That's
so
great.
How quickly will I let you know it's time to change a slide? I can't
just say next or just next slide. Yeah.
So my research now is, when I came back, it was these new obesity care guidelines had came out, and it was that we should be providing diet counseling to patients to help reduce cardiovascular risk factors. And so when I came back, I did a survey of physicians because I wanted to know if physicians were in fact providing nutrition care to patients. The biggest issue was that I couldn't get many to even respond. And when they did, they said that they were either providing it and they didn't feel like they had people to refer patients to in the area. So then that became the focus, is how we would get better access to nutrition care providers. And that's where the telehealth came about. Okay, go to the next one. One more. Okay, so when we look at our statistics, I know that probably none of this is new to any of you, but when we look at statistics and we're ranked number one, we usually think that that's a positive thing, and we are now, this changes a little bit here and there. We fluctuate a little bit with Mississippi and Alabama, but currently the most recent data is showing that we have the highest rate. If you look in the under rate, you'll see that next to the range, we are at the high end of the range throughout the United States in obesity. Specifically, overweight and obesity among men, 77% of men in West Virginia are either overweight or obese. When we look at the age groups, middle-aged adults come out as being at the highest level there. So we sometimes focus, and rightly so, on prevention in younger ages, but we do know that in West Virginia we have a large baby boomer population that is aging, and they're entering older adulthood with higher rates of chronic conditions like obesity, cardiovascular disease, hypertension, which decreases functionality and quality of life. So we wanted to target that age group in our study. So we were looking at men. That's the biggest question people ask me is why men? And one of the main reasons was that when we did a focus group and we were asking women what was the biggest barrier to eating healthfully, what do you think they said? It was men, right? So their husbands wouldn't eat the healthier foods. They were having to cook two different meals, and that made it more difficult. And so that's another reason why we focused on the men. So men have higher rates of obesity. And can you go ahead one more, Leslie? Yes. They have higher rates of obesity, but they seek care less often. So women may be able to go to perhaps a program like Weight Watchers or something like that. Men, especially in West Virginia for some reason, steer away from that for the most part. So they were telling physicians they really didn't have, alternatives for treatment. So when we look at one more slide, Leslie, so we know that we have these diet-related health disparities. So what do we do about it? Well, we already have clinical care guidelines that are telling us what we should be doing. And the United States Preventative Task Force Services recommend that anyone who is overweight or obese and has additional risk factors, so that can be elevated waist circumference or diabetes, prediabetes, if they have one other risk factor, that they should be recommended to behavioral counseling for healthy diet, physical activity. So one more slide, Leslie. So these primary care physicians tell us, though, that they don't have time within the amount of time a patient comes to see them, that they don't really have time to get into details. So they usually give them some short version of what they should do, and it's not usually the priority of the visit for them, or is what our survey told us. They didn't feel comfortable going into some of the different diets, and they didn't have those programs on site, which is the gold standard recommendation, that you have an on-site intensive program. Well, we don't have those routinely in primary care offices. So we have this need for access to care. So go ahead, one more. So we have the third lowest rate of dietitians in the state. So we don't have providers in all areas, and reimbursement is a big issue. So even when there are providers, many of the payers aren't reimbursing for different kinds of nutrition counseling. So go ahead, one more. So we have a need. So the recommendations are that we kind of target these interventions to people who are really in these subpopulations that have high rates, and we fit that exactly. So we developed a program with some graduate students that I had, and we developed a program that was just based on what was traditionally used to be called the exchange system for people who had diabetes. So that's the diet model that we use. So it wasn't anything extravagant. My philosophy is that eating healthy doesn't have to be difficult, and that a lot of patient care is partly what information that you're giving them, but really about this rapport and this relationship that you're building with the patient to let them know you're a part of their healthcare team. And so that's what we tried to do. And that's more difficult. I was skeptical of using telenutrition to do that. I'm a bit old school. Maybe you see that now, that technology isn't my strength. But fortunately, I have some good graduate students who are more comfortable. But I like to look in a person's eyes. I struggle with how we were going to make this connection with people to help them through the computer. And so that was one of the obstacles that, from my point, I had to kind of overcome. So go ahead one more, Leslie. So telenutrition is a form of telehealth, which is a broad term of different kinds of programs that can be delivered for lifestyle interventions. Telehealth, as far as nutrition goes, is not well researched. And that's partly why we don't get great reimbursement across payers, is because we don't yet have the documentation to show that it's equal to what we would give for people for face-to-face visits. One more, Leslie. So there are different kinds of telehealth delivery, and we chose to use the video conferencing that was real-time and two-way. So there are multiple ways that you can deliver some of these health models, telehealth models. So there's store and forward, and so that's where you can, people think of dermatology sometimes when they think of store and forward, where they're maybe consulting with another physician and they're providing pictures or something that they can use. For us, that sometimes we're providing nutrition education and we're just storing that and the person can go and read on their own. There's remote patient monitoring, so some sensors in the equipment like blood pressure monitors or blood glucose monitors where the information is then transferred to the provider to share. And then there's the mobile health, which sometimes is like targeted text messages, is an example of one of those. But we chose to do the video conferencing. So we did video conferencing that was real time and two-way, so exactly similar to what we're doing right now. One more time.
Nope. Sorry.
So we chose to do our study. We had some funding from the West Virginia Clinical and Translational Science Institute to conduct the study. Back just a few more. And even finding physicians to participate was a struggle initially. And so I even had the West Virginia physician group to send out requests to try to get some physicians, and we didn't get many responses at all. So then I just did some legwork and went to some physicians in the area that I'm familiar with, Harrison County, and the two that I went to immediately said, yes, we will help you, and found two more physicians. So then we had 4 physicians that were at 2 different locations that helped us to recruit patients. And recruitment has been in the past very difficult for us for healthy eating type studies, whether it be focus groups. We struggle with getting middle-aged adults to participate. So we were worried that we wouldn't get enough people. Would middle-aged men want to do a weight management program over the computer, right? So we didn't know. So we aimed for around 60 participants. And what helped us most, and the patients told us this afterward, is that the physicians sent letters to people who qualified, and the people called us and said, my physician thinks this is important. So the letters helped us. We came in the next day, the next Monday after we had sent the letters, and the graduate students were thrilled because the phones were lit up, and within a few weeks we had all of our 60 participants. So it was a successful recruitment. People seemed to really, I don't know if it was these physicians specifically or maybe in the state, that they really were interested in what their physicians wanted, for them. So we did our informed consent, and we had 30 patients, or 29 randomly allocated to the nutrition intervention, and then the rest were to an enhanced usual care. And we struggled with the control group because you have these 60 men who want to participate, and to put them in a control group where they weren't going to get any interaction was not what we wanted. So we gave everyone in the 60 patients the same diet information. So they came to a baseline assessment visit, and all patients got the same diet information. We took their anthropometric measurements and calculated their estimated caloric intake, and then gave them all the same diet information. The only thing different between these two groups is that one group had weekly interaction with a registered dietitian to help with behavioral counseling and implementing the diet plan. So we thought that would, enhance usual care. It wasn't what the physician themselves were providing. We did provide them some literature on healthy eating. Okay. So we took men who were 40 to 70 years old, and at that time that was the baby boomer group, and then a little younger, so that we could capture that middle-aged and baby boomers. All of the patients had a BMI of 30 and had to have one additional health condition. So they either had hypertension, diabetes, prediabetes, high cholesterol, high triglycerides, and then they had to have high-speed internet access, and that ended up biting us a bit because high-speed internet access, I think, maybe is the reason why we didn't end up with a lot of patients who were low income. We had a very high education and income group. And then our exclusion criteria, we took mostly healthy people that weren't on medications for weight management or steroids or insulin, and not consuming more than 2 alcoholic beverages a day, just because of the caloric amount that would have, and hadn't had any major surgery. Okay, go ahead a slide. So we provided a caloric recommendation for them. They came back so we saw them at baseline at week 6 and at week 12. The people that were allocated randomly to the intervention, we gave a weight scale and then a monitor for their computer, a video cam. And then the groups received the same diet information, and I met with each patient myself and gave them about a 10-minute overview of the healthy eating plan. And then the other group, we didn't see them again until week 6, and then week 12, the other group talked to the dietitian weekly. The first, when I say weekly, most of those consults were by telephone, a health coaching phone call. We did the video conferencing only 3 times. So we did that at week 3 different weeks, spread a month apart. And then in between those were just phone calls. And we scheduled those. So people picked at their initial visit a day and time that would be their day and time. So that scheduling would be clean. And so somebody said, Mondays at 8 o'clock in the morning are good for me. That was that person's time through the whole 12 weeks. And so our outcome measures were for effectiveness. So did they lose weight, and did they reduce their caloric intake? And then we looked at some secondary measures like waist circumference, and then diet quality. And then we were really interested in feasibility. Of course, we were interested in effectiveness, but feasibility, we wanted to know if we could get enough people to register. We wanted to know if people would stick with us that whole 12 weeks, if they would adhere to the program, and if they would be satisfied with the communication via the video conferencing. So because in the end, we wanted to do a longer term for 12 weeks. We know we can get most people to a diet for 12 weeks. We're really interested in what happens after that, but we wanted to first see if we could get people to participate. So one more slide, Leslie. Okay. So the diet we did, we tried to take a little sports twist, and we called it the Healthy Habits Handbook, and so we gave a little sports theme to the program throughout. So it had diet-related information. Then we gave them self-monitoring tools. So we gave them like a weekly weight log where they were supposed to weigh themselves and record that every week, a fruit and vegetable tracker, and a goal planner. Both of those last 2 items weren't used often by either group. And then we gave them an individualized calorie goal. So that was the diet component. It was not elaborate. It was more healthy eating based on the plate method. You know, the plate method where you take the plate, half the plate is non-starchy vegetables, a quarter is a lean protein, and the other quarter is a carbohydrate food. And then we added some dairy throughout based on their caloric amounts. So we tried to keep the diet part simple. Go ahead, one more, Leslie. So again, everybody got the same information. The only difference was in the behavioral support. So one more slide. So this is Michelle, and she was the only dietitian. She came back to get her master's degree, and she provided all of the nutrition counseling. So she did video conferencing at weeks 1, 5, and 9, and she considered all of their lab work, their medication, during those 3 visits, so she could change the pattern as they decided between the patient and the dietitian. And then they did health coaching calls in between those. So weeks 2 through 4, 6 through 8, and 10 through 12. And those were patient-led. So we're often asked if we had a schedule, and at week 4, we talked to everybody about one certain thing, and we did not. We let the patient determine what they wanted to talk about based on what they were struggling with. Michelle was at the university, and the patient was in their home, which is a little different than what we would normally get reimbursed for when we do get reimbursed for telehealth, because at that point, the patient still has to go to a clinic. We wanted to actually take it to the patient's home, and we had support through the WVU IT MDTV group, and they were incredible in that this was the first time that they had taken it into patients' homes, and they had someone to help us throughout and help Michelle with troubleshooting. So that was what helped them, that was helpful to us. Okay, one more. So our participant characteristics, 92% were non-Hispanic white, which represents West Virginia. About half had college degrees and an income over $75,000, which is pretty on the high end. It's about the West Virginia average. 100% were obese and had a waist circumference greater than 42 inches, which is a health risk. 95% had hypertension. 90% had high either cholesterol or triglycerides. Half had diabetes or prediabetes. And then as far as the experience with using video conferencing, only a total of 37% had no prior experience with video calls, so it was all new to them. Okay, one more, Leslie. Can you advance the slide?
Oh, I have been. Sorry, is it not changing on your end?
No.
Uh-oh.
Maybe it's my computer. Let me look. What slide are you on?
Weight loss greater than or equal to 5% of baseline weight.
Okay. So that's our amount. So losing 5% or more of your baseline body weight is what we would consider to be clinically significant, because that's the point where in other studies we didn't measure health outcomes. So the American Heart Association obesity guidelines say that at that point, that's when we can see reduced blood pressure, reduced for medication for blood pressure and glucose. And so that's kind of our goal. And in the end, we did not have a difference in weight loss as far as pounds go between groups. And the only significant difference in this study through any of the outcome variables was that a higher proportion of the intervention group, so 70% of the men in the intervention group lost 5% or more of their body weight over that 12-week period, and only 41% of the control group, which is still pretty good, even in the control group. But as far as any of the health markers, if you go on to the next slide, there was a significant decrease in body weight, waist circumference, percent body fat, change in BMI percentage, and KCAP from calories from within each group. So if we just look within each group separately, the change was significant. But when we look between groups, was the intervention group lose more than the control group, they did not. Both groups had successful weight loss, but there was not a difference between groups. And so we, of course, were a little saddened by that because we hoped to see that the dietitian providing the nutrition counseling had some other changes. But we did see some differences in diet. So weight isn't our end marker of health. While that was the goal of this project, we saw some differences in healthy eating for that group. And then we also think that maybe with time. So these men were motivated. So when you think of a traditional control group, they're not receiving any treatment. But all of these guys were motivated to make change or they wouldn't have registered for the program. So when they came, they probably knew a little bit about what they needed to do. And for 12 weeks, were able to do it. So we think that maybe with time that we would be able to see that difference. And then I had a physician to tell me that I shouldn't be discouraged by it, but that maybe there is a lesser frequency of interaction, which would be more cost effective to see the change in patients. And so that's the route we wanted to go at this point, was to see if we could do like a comparative effectiveness trial to see how low of an amount of interaction would a patient need to have this weight loss, and could that be sustained over time. So you can go to the next slide.
Okay.
So are you on diet quality changes?
Yes.
So in diet quality, so this was the exciting part for me because we were able to get people to eat healthier. Both groups had a significant change in their total quality of their diet, but specifically they consumed higher amounts of total fruit, whole grains, and their fatty acid ratio, so that's the healthy fat to saturated fat ratio, were improved. And they all had lower intakes of sodium, refined carbohydrates, added sugars, and saturated fat. So those are all of the things that we want to see. So we were happy about that. The difference between groups for us was that we saw greater improvements in greens and beans and fruit for the group that had the dietitian counseling. So on the next slide, our conclusions were that the project would be feasible for a longer term trial because we had good recruitment. Our target that we were looking for retention and satisfaction was 20%. So we said that if we could get 20% of the participants to stick with us, and that 20% of them were very satisfied with the program, that we would deem that as feasible for a longer term trial. And in the end, we only lost 3 participants. So we had 5% dropout rate, which is really good for a weight loss trial. And satisfaction was greater than 20% in both groups. So we deemed that it was feasible for a larger trial, and as far as effectiveness goes, that we did have effectiveness in both groups. So we would love to do a larger trial and try to reach some of the lower income population. There were technical problems. So of the 81 calls, we had 27 participants, and they each had 3 calls. Only 43% of the time were there no issues. Other times there were frozen videos, delayed in voice, fuzzy picture, unable to establish a video. And so I'll say that, what I did today was just to show you that those things happen. And some of them, Michelle monitored everything, how long, every little thing that happened, what we had to do to fix it. Sometimes we noted that it was probably our lack of experience, and had we been, because this was all new to us and the program was new to us, that maybe some of those things we could fix as we learn over time. And some of those ended, I think only 2 of the video calls, our backup plan was that if we couldn't get connected, we would do that by telephone, and twice we had to do that out of the 81 calls. The rest of them we were able to fix, and we did a pretty extensive survey afterward, and patients overall were still satisfied with the program. I know that Michelle, at one point, one man was frustrated. She was trying to get the video on, and she couldn't see him, but they could hear each other. And she said she heard him mumble to his wife, "This is the last time I'm going to fix my hair for one of these things." So he must have prepared himself for the face-to-face video, and was disappointed that she couldn't see that. So, so the next slide, the limitations. our limitations were with the income and education level because we didn't feel like that represented West Virginia. In men, unlike in women we know that people who are lower income have higher rates of obesity. But we don't see that in men. So we do think that regardless of income and education, we still have a population that's high risk for cardiovascular disease because of weight. We were probably maybe, at a advantage because we had people who could implement some of the increase in fruits and vegetable consumption. So they had the monetary means to purchase those foods and had better access. So that could have determined some of our results. So the sample size was small. We knew it would be, and the short-term duration, but that was the feasibility part of the study. So we would like to do that in a larger population and to try to get into some different care models that would give us access to lower income patients. And then on the next slide are same thing. We want to see if it's sustainable. And so the considerations that we have when we're doing that is telehealth is the HIPAA compliant platform. And we used, like I said, the MDTV, what they provided, and they used the video platform, which is very similar to what you use here. The connectivity, to me, that's still that's the internet connection. We still have an access issue with some people. And then the personal connection, do people connect on a real time, face to face? We know that store and forward isn't as beneficial. But when we asked people at the end if they thought that it could be all telephone calls, some of the men said yes. They felt like that they didn't need to even see that person one time. I'm not convinced of that. So on the next slide, the benefits. There are definite benefits in different models of care. So we have people who don't have access to dietitians or they have staffing issues, and this could definitely increase access to nutrition care. It could help with costs associated with traveling. It could increase, your ability to see patients on a repeat basis. Sometimes we have a lot of people who don't show up for visits because if they have to miss work for that 9 to 5 days a week, and we did this even in the evenings and on the weekends. So that was convenient for patients. So there's reduced travel time, some savings in wages. And the next slide, we still have barriers. Reimbursement is still an issue. We didn't have to worry about that in our study, but from many instances, reimbursement to the home isn't covered for some nutrition care. We need to determine the number of visits that are adequate to help save costs. The need for technical training and equipment is important, and then that high-speed internet access would be a problem in some areas. And so our outcomes data is needed, and what I mean by that is I've had many people call me and they want to do nutrition programs and tele-nutrition programs, and trying to get them to try to capture that through research is so important, because showing that it works and that it's beneficial and helping people to see what the barriers are and what you did to overcome some of those barriers really helps people to implement it on a wider scale. And then when we're able to do that and to show the effectiveness of it, that's when I think the payment will follow the model. And so then there's a few, I've just put on the last slide a few information resources that provide information on if you're implementing a program and some of the things to consider. So do you have any questions?
All right, let me go ahead and I'm going to stop sharing.
Okay.
Just quickly, and I'm going to unmute people so that anyone who has questions can go ahead.
I did have a question. So earlier in the beginning of your presentation, you talked about nutrition counseling and that anyone overweight should be referred for behavioral counseling. is that, two questions, I guess. One, is there a list of places that people can go in the state to get that kind of counseling? And then as secondary, are there any materials that you're aware of that have been developed for individuals with disabilities or specifically developmental disabilities for nutrition counseling?
Okay, those are great questions. So the first question is who should get the services? So the obesity care guidelines that I mentioned and the U.S. Preventative Task Force recommendations, those are for primary care physicians. So the recommendation to primary care physicians is that when a patient comes in, that we should be assessing weight and waist circumference even. And if a person is overweight and has an additional cardiovascular risk factor, so overweight plus diabetes, prediabetes, hypertension, or if they have obesity, so that BMI of 30 without any additional risk factors, that they should either themselves be providing the behavioral nutrition counseling or they should be referring to someone who can. And so whether or not there are places to do that, you know, some like PEIA has a weight management program that is beneficial. There are some community services and hospital outpatient for like the diabetes prevention program. But overall in West Virginia, there aren't a lot of primary care offices with in-house dietitians. And so that's why I think that telehealth is a great opportunity to kind of give those people some access. As far as specific recommendations for people with developmental disabilities, there aren't really even any, just unless you're doing one of those programs like the diabetes prevention program, which has a lot of information that is printable, handouts and things. Most of that is really on an individual basis because that's a large group of people who have very different needs, right? I mean, we would say that for anyone. So a lot of times that's finding a dietitian that will be willing to create those after they do their assessment. They will create their own educational materials to try to do that. I know that when I was working in Maryland, I was able to go to assisted living homes. 3 people lived in a home, and then they had a staff person who helped with meal planning and purchasing. And so I was able to go into the homes and help them all as a team. They were struggling because like maybe one person had diabetes and another person needed to lose weight, and how do you prepare meals for different people? And it's the same. I mean, you say for someone with developmental disabilities, but people, you know, are of different education backgrounds and willingness to do some recommendations that we make. So we have to take that on an individual case-by-case basis, I think. I hope that answered your question.
It does. Thank you.
Melissa, we also have, Grace, are you still on? Grace had listed a question on chat. I wasn't sure if you...
Yes. Can you hear me?
Yes.
Yeah.
Okay, great. Yes, Dr. Marra, I wanted to know if you had any thoughts for any kind of longitudinal follow-up, like the time span of possibly surveys, like maybe at the same points in which you implemented the diet, maybe like a 6-week follow-up, 12-week follow-up. How long do you think it would be beneficial to ask follow-up questions for your study?
So the recommendations are that you have an active intervention stage and that should last at least 6 months. And then you have a maintenance phase and then a follow-up phase. So really a nice 2-year span of taking someone through the active phase where you start out more intense with the meetings and then you gradually reduce that. So then you would reduce from, we were weekly, so then we could reduce to bi-weekly, to once a month, and then to do follow-up. And then even after that maintenance phase, following up with people to see if they're still implementing the plan. So 2 years would be ideal. Most research studies that are doing the full intervention are generally for about a year. And that's probably because of funding. It's hard to get funding well past that. I had written a grant recently to try to do this. Dr. Becker at the Medicaid office, and I wrote a CTSI grant to try to get this into diabetes medical homes, and we tried to do that for a year. It didn't get funded. Funding is difficult to get, but you're right, the 12 weeks is nothing. We know we can get people to do it. We didn't know we could get middle-aged people to, the middle-aged men on the computer. So we learned a lot about that. But now that we know we can do that, we do want to do exactly what you said, to take that, throughout the year, and then to follow up even up to 2 years would be great.
Okay. Any other quick questions? We have 2 minutes until 3. I don't want to override any questions.
This is Mark. I have a comment or question.
Yeah, go ahead, Mark.
Okay. I was just wondering if she was working with or had talked with Dr. Steve Davis there at WVU. He's doing the telehealth research right now. We're working on a subcommittee with him. It's not specifically about nutrition, it's about telehealth, trying to implement a telehealth program here in the state. And I didn't know she'd had any contact with him.
What's his last name?
Steve Davis. He's a professor there at the university.
No, I don't know him.
Let me look at something real quick. I can give you another name. Trying to see if they have the other. There's another doctor up there, and I'm not sure who. I can't remember her name. Dr. Mallow is the other one. And anyway, they're doing a research grant, and we're working on it with the Aging Disabled Waiver and Traumatic Brain Injury Waiver program, trying to, develop, just telehealth in general. But and just FYI, I've been on the PEIA weight loss program for a little over right at a year and a half now, and it's only lost me 110 pounds. Oh
my goodness! Congratulations.
It didn't lose you that. You lost that.
Well, it's gone for good this time. But it takes more than, the counseling is not a bad idea at all, because it takes more than just trying to eat and trying to exercise. You've got to change. It's a whole mindset, behavior change in anybody if you want it to be a true lasting. And that's with any chronic problem. We don't look at it like it's a chronic medical problem, but believe me, I got to the point where I realized that after all these years.
Well, nice job. It is a mindset change, and that's hard sometimes. I mean, I know better, and sometimes, it's hard for even those of us who know what we should be doing to do that on a daily basis. But we try to, be a role model first. But sometimes I see my students come in, and they're way ahead of the game than I am. But I tell them they have more time to prepare those meals and to get that exercise in. But it's hard sometimes.
Mhm. Yeah. So it's interesting to see, telehealth efforts make sense for our state. It doesn't make sense for people to drive multiple hours to learn that they need to be more physically active. So this is great that you guys, both of you, are doing this. So and thanks for talking about kind of the practice and the feasibility of it as well, because I know a lot of people might want to do it, and then when they get into it, it's really complicated. You want to do it, and you want to do it right. So thanks for sharing that part of it too.
Thanks for inviting.
Oh yeah, anytime. You can come back. Anytime. Present your next study. How about that?
Well, my next study is not on telehealth. It's still on cardiovascular risk reduction, but we are studying the bioactive components of eating ramps on blood pressure. So we're excited about that study.
All right. You need to present that. We need to schedule you during ramp season when it first opens.
Right.
That'll be great. All right, well, thanks, everyone. Dr. Marra, thank you very much for your presentation. You rolled with it. You had technical issues, and you rolled with it, so thank you.
I'm sorry.
No, you couldn't even see the slides at one point, and you still went through. So I thought everyone did really well. Thanks, everyone, for joining us today and spending your time with us, and have a good afternoon.
Thanks, Leslie.
Thank you. I'll talk to you later.
Bye.